Here to help us with some of those is Dr. Sue Decotiis, board-certified weight loss specialist, and William Solomon, former pharmaceutical executive and founder and CEO of the Accreditation Council for Medical Affairs. Welcome to both of you.
Merry Christmas.
Dr. Decotiis, does the pill form present any changes other than the actual form as opposed to the pen injection?
Well, I believe the studies show that it's absorbed pretty well. But in my practice in New York City, I really have found that the drug Tirzepatide, which is Mounjaro or Zepbound, works a lot better, and studies show that. So, yeah, I mean, I think a lot of people, if they can get it covered, it's great, because a lot of people are afraid of the shot. Though in my practice, most people really adapt to the injection. My biggest concern, and I'm really a purist, I do weight loss every single day, is that I have so many patients coming to me who are accessing drugs on apps or directly from, online platforms, or directly from the pharmaceutical company, and they're not getting proper medical guidance. They're losing weight, but they're not losing enough fat in order to get the metabolic changes that we want for long-term health. So that's my beef. I'm just afraid that as these drugs become more widely available, people are going to be accessing them and not using them properly.
William, I see you nodding here. Diabetes medication has been around forever. How did pharmaceutical companies discover these injections could be used as a weight loss medication for many Americans out there?
Yeah, so in early clinical trials with Semaglutide, basically what they found was that these patients were losing weight. And, you know, the better you are at improving insulin sensitivity, the better you're going to be at losing weight. And I think Dr. Decotiis hit a really important point, and this is something that I'm really concerned about, is that obesity drugs, they're still seen as budget busters when it comes to the payers, or the insurance companies. So remember, from the insurance company's perspective, even though these are now in a pill form, they look at it like, wow, now we're going to get tons more patients wanting to use these drugs. So I actually think you're going to get more pushback in terms of utilization control from these payers, from these insurance companies. So, because remember, a lot of patients don't want to be in an injectable. So if now you're going to be putting it in a pill form, more people are going to be willing to try it, to Dr. Decotiis' point. And that's going to mean the more control from the payer, more prior authorization denial. And remember, in the United States of America, the #1 reason for care delay is prior authorization. So that to me is the concern, especially because, as Dr. Decotiis I'm sure knows, obesity is related to many different types of other conditions, hypertension, cardiovascular disease, so forth and so on. So, you know, I think, you know, the jury's out in terms of how the payers are going to react.
Doctor, we all seem to know someone who's had success with an Ozempic or similar injection, like you mentioned, Wegovy, Mounjaro. But how do you wean yourself off if you've reached that weight loss?
What a great question. Yeah. So in my practice, I use a lot of data. So every patient is put on a body composition scale. So I know what is the patient's body fat, what's their muscle mass, what's their level of hydration, what's their bone mass. I'm also now using a breathalyzer machine to determine how many calories they're actually burning each day. Wow. And toward the end of treatment, when we can really see the body fat go down, these patients are actually burning more calories because they were insulin resistant before. And these are non-diabetic patients. And some of these patients only had 20, 30 pounds to lose. So the answer is you have to get the body fat down. Once it's there, you keep it there for a while, right? Because the body has this automatic reset. You know, after you lose weight, doesn't mean the body wants to hold on to that, right? But if the body gets used to it, so we keep the body at that weight with the medication, we slowly taper the drug and see how the patient does. But the data gives me the answer. So if a patient is just weighing him or herself on their home scale or on a regular doctor's scale, it's like driving on the highway without signs. You don't know where you're going. A lot of people are going to gain the weight back. And to the other gentleman's point, yeah, the insurance companies are going to say, what? You want me to pay for this again? So I think there can be pushback. So I think the key here is really good care. Patients have to seek out someone who can really, a medical weight loss specialist, someone that uses data, body composition scale, to really be sure that they're doing it the right way. Otherwise, it's a waste of time.
I'll give you the last word very quickly, William.
I was just going to say, the thing with all these obesity medications is this. You can lose weight on them. The issue is weight maintenance, weight loss maintenance. Can you maintain the weight loss? That's #1. And the second thing that I'm curious to see is, with the insurance companies, what are they going to require in terms of, pushback in terms of like time limited approvals? Are they going to only approve it for 6 months, 12 months? Then what happens when the patients can't get access to it? Are they going to make sure that, you've done certain things, exercise, diet, tried other therapies? So all that's going to play a really important role long-term in terms of patient success in these therapies.
Yeah, I have no doubt a lot of us will be talking about this in 2026. Merry Christmas, guys. William Solomon,
Merry
Dr. Sue
Christmas.
Decotiis. See you soon. Thank you again.
Thank you.